Hello, everybody. Mayor Clark here again with another update on our local response to COVID-19. Statewide, as of yesterday, we had nearly 1,700 people diagnosed with the virus. Unfortunately, 80 of those people have died, but 790 have recovered. So I'm so happy to see some positive numbers like that. Our local healthcare providers continue to work around the clock to care for those affected by COVID-19 here in Norman and Cleveland County. Joining us today to talk about those efforts is Dr. Clay Cochran, a neurosurgeon from Norman Regional Health System. Dr. Cochran, thanks for taking the time to update us today.
My pleasure. Thanks for having me. It's an honor to speak with you today.
Well, I know that Norman residents and, well, frankly, Oklahomans appreciate these kinds of updates and getting helpful information. So I'm really excited to chat with you today.
Oh, me too. I wanted to just begin with an opportunity to kind of touch base with you and the public about where we stand on our surge preparations. I know that's
excellent. I think that's so important because we're hearing that, New York may have hit their peak, but as we know, things take a little bit longer to get here. So we've seen estimates that our surge is coming. So that surge that we're talking about means a significant wave of new COVID-19 cases that could potentially challenge our hospitals here in Oklahoma, specifically here in Norman. So how is Norman Regional preparing for that potential event?
Right. So getting a call there. So the surge is expected somewhere based on modeling out of the University of Washington to be around 3 weeks from now. April 21st to the 23rd, somewhere in that is the sort of anticipated peak right now. Modeling is based on, of course, past data. And so as time passes and things change and the rate or the trajectory of increase in cases and deaths change, that modeling changes as well. So what we're saying now may not be accurate at all going forward, but it's important to at least anticipate. And so that's something that we've done using that modeling, mostly based out of UW. What Norman Regional is doing right now and has already happened is increasing our testing capacity. We're partnering with a lab called IMMY, that's IMMY. It's a lab just north of town here. And we've been able to go away from depending on the Department of Health for testing. And we're using them with turnarounds as rapid as 4 hours, but at the maximum 24 hours to get the results back. That's helping our providers be a lot more nimble in treating patients, quarantining patients, and protecting our staff, as well as utilization of PPE. In the beginning, we had testing going for 5, even 7 days sometimes, and we'd keep people in quarantine, and every time a nurse would go see that patient, they would put on a gown and gloves, and that would be lost personal protective equipment that we'd never get back. So that's a huge change. The other thing we're doing is looking into expanding our bed capacity. We have the means to increase our capacity here on the Porter campus and at the Healthplex by about 40%, taking our total bed capacity from 387 beds up to about 500 beds. The hope is that we don't need to do that. We're not needing that right now. Our volume right now is seems to have steadied without a non-linear increase in cases over the last 3 to 4 days. But we are still seeing quite a bit, and certainly some of those are critically ill patients. The other thing worth mentioning, if we have to move to like a plan B or plan C, we have some space at an LTAC that has actually been closed but could be easily reopened and utilized on Robinson Avenue. We also have 2 military-style tents that can be erected within 24 hours at the Healthplex to establish a field hospital capacity quite easily.
Well, so many things to say about that. First of all, if you would have told me I'd be having a conversation about field tents in case we need them to address a pandemic, when I got sworn in, I would have just laughed at you. But it's kind of our reality today. And I'm so grateful that you all are prepared as you are. And again, while this sounds kind of scary, I'd much rather hear that you're ready for it than like, oh, we'll figure that out when we get there. But we were the first in the state to issue a stay-at-home order, and our order is actually more restrictive than that of the governor. Do you think that will be helpful in reducing or flattening the curve, as we've said many times, and hopefully not needing all of these extra preparations that Norman Regional has put in place?
Well, actually, we're seeing that already, Mayor Clark. We have seen quite a downturn in that, again, nonlinear increase in cases in Cleveland County in particular. As I'm sure you were following the numbers early on in exposure and tracking here in the state, Cleveland County was one of the highest, especially with the cases coming out of the Grace Living Center or Grace Nursing Skilled Nursing Facility. And we had some early deaths there as well. We were neck and neck with Oklahoma County, who, the population there, of course, is much larger. And, since these other more populated localities have had higher case counts and whatnot. But our bed utilization projections are actually down over the last few days compared to where they were. So thank you very much for what you've done along those lines. And I think it is making a difference.
I'm so glad to hear that. So you've talked a lot about bed utilization and making sure we have space. How are we doing on supplies and PPE?
As of right now, we're doing fairly well. We canceled all elective surgeries starting mid-March and started making conservation efforts at that time. We have been reusing PPE. Our system wide, we were using about 1.3 million pieces of PPE a day. Which blew my mind when I first heard that. But that came from our chair of surgery. And if you think about it, every time you go in a room, you put gloves on, and this is happening through 500 different, about 387 different hospital beds in our system, with every nurse and every physical therapist and respiratory therapist and occupational therapist, social worker. So it really adds up so fast. And so the conservation efforts have been phenomenal. And talking to administration and our central supply folks in anticipation of this interview, we're doing okay. We're
awesome.
We need.
Hopefully still accepting donations, though. I know on the foundation website, there's a list of specific equipment that you all have asked for. And I know that the Chamber of Commerce and Cleveland County have partnered together to provide a drop-off Monday, Wednesday, and Friday at 3 to 5 p.m. at the Cleveland County Fairgrounds.
Yeah,
all right.
3 to 5, that's good.
So PPE, we hear that deals a lot with kind of equipment for our first responders and medical professionals, but the CDC recently changed its stance on masks for everyone this week, now recommending that everyone wear some type of face covering when they go out in public. I think I showed off in one of my updates my mask that a resident made for me. I know I've seen people use bandanas if they don't have like an N95 mask. So can you tell us what's behind this change in recommendation? And are there any tips you can share on evidence or on how to wear and handle them properly so we don't cross-contaminate?
Yes, absolutely. So what's being recommended by the CDC is a mask kind of like this. This is a non-surgical mask, or it can be used in surgery, but not typically what we do use. These masks specifically are used for isolation. They do need to be placed over the ears, like so, and need to be form-fitted around the bridge of the nose so that it helps prevent exhaled breath from coming up and around to the best of our ability. The proper way to take off is to touch the loops. Sorry. Proper way to take it off is to just touch the loops and leave the front of the mask alone. The front of the mask should be considered contaminated. It is something that can be sprayed down with Lysol, allow it to dry, and it should be ready to go again. The same is for cloth masks, bandanas, and things of that sort. This is an alternative that's reasonable. We're seeing lots of cloth masks that are reusable, Besides spraying it down with Lysol, a coarse cloth mask can be washed in a sink or the dishwasher or a clothes washer, and all of that will facilitate sterility. N95 masks are different. Unlike this mask is only intended to prevent you from giving the virus to other people, but it won't prevent other people from giving you the virus. An N95 mask facilitates more of a complete protection, both with exhaling virus and inhaling virus. And this is a mask really intended just for healthcare workers or people who are going to be participating in the care of somebody who has a known viral infection. Simply because they're a scarce item. If they weren't so scarce, of course, this would be a more complete way to protect ourselves out in public. The idea behind this works really well if everybody does it. And that's why the CDC is recommending that everybody use this mask. This mask only works if everybody uses them. This works if only one person uses them. So I hope that answers your question.
It does. You know, we've been asked from the city side, are we going to do a citywide requirement? But, you know, we have over 125,000 people in this town, and I have a hard time requiring something that people may not have access to. And until we get enough numbers where we can provide one, I think the best we can do is strongly recommend. And then pro tip, if you have one that ties like mine, be sure you tie these before you wash them or put them in a garment bag. That was what my wonderful volunteer had reminded me when she handed me this one. So to kind of pivot a little bit, we hear a lot about, oh, go ahead.
I said, that's absolutely right. I guess the only thing I would add is, you know, the cloth coverings of a bandana or some dense cloth really does suffice. Yeah, I understand your position. That's a difficult decision to make. But certainly following the CDC guidelines is the way to go. These don't need to be worn in public as long as you keep your distance. The minimum of 6 feet, I think, is a minimum. You know, when you're out in public, walking down the street, whatnot, as long as you're keeping ample distance, 6 feet or more, you shouldn't need the mask. This is for indoors. When you go inside, that's when this really should be used at all times.
Well, again, I can't stress the social distancing enough. I've been jogging around my neighborhood to kind of manage stress and keep myself healthy. And I fear I might have offended some of my neighbors where if we're going the same way, I'll just turn around and go the opposite direction. So we're all doing our part for social distancing for sure. But to pivot a little bit, we've heard a lot about the lung problems, obviously, with the ventilators and the dry cough that are caused by the coronavirus. But your field is neurosurgery. Is there any evidence of how COVID-19 might affect the brain?
Yeah, there's not a lot of information on that. I actually have been looking into that a little bit. The SARS virus that was sort of popularized and people knew about, that was affecting mostly Chinese nationals in the early 2000s. This is basically the exact same virus from a genetic standpoint. It's actually called SARS-CoV-2. And the first SARS virus was SARS-CoV. CoV, C-O-V, is just the acronym for coronavirus. This is essentially identical. There's another one called the Middle East respiratory virus, or MERS-CoV. And this virus, they're all very similar. And there was a research article out of China, Yan Chao Li, in late February, printed an article in the medical, Journal of Medical Virology that did draw the comparisons from how the older SARS virus and the MERS virus actually does infiltrate the brain. There is some suggestions that it enters through the nasal mucosa and actually gets into the olfactory nerve, which is one of the cranial nerves that directly communicates with the backside of the frontal lobes, and then also parts of the brainstem. These other viruses are known to infect the brainstem. And the brainstem is where we have the control centers for our heart rate and our ability to breathe. And there is some clinical evidence that current COVID-19 patients are having respiratory suppression. completely separate from the pneumonia to where they actually can't breathe deeply or become completely unable to breathe spontaneously. In other words, if they suffer some manner of respiratory depression, neurologic depression, they stop breathing spontaneously. And it is known that these viruses can, to what rate we don't know, but they can infect the brainstem significantly. So while that's awfully scary, it just helps inform us as providers about how to think about this when it comes to prescribing certain medications and doing all we can to ensure our patients aren't neurologically suppressed as they're battling their pneumonia. The only other way it may correlate is there are neurologic means of causing pneumonia to be worse that look very similar to the acute respiratory distress syndrome. That seems to be the primary thing that kills people with the coronavirus. And so a neurologic stimulus to make that kind of lung disease worse is also a role that it may play.
And then I've heard some cases of COVID-19 have suffered a loss of smell. Is that somehow a neurological a side effect as well?
Yeah, that's exactly right. So the studies with these other very similar viruses that showed that the one potential mode of transmission is through the olfactory nerve. The olfactory nerve is the nerve that carries a sense of smell. And so it may be that the sense of smell and also very closely correlates with the sense of taste through the connections in the what we call the hind forebrain. Those connections with sense of smell and taste may represent virus coming through the olfactory nerves and entering that way. So it does not necessarily mean that this is a precursor to viral meningitis or viral encephalitis, which is an actual direct brain infection of the virus, as we're talking about, because we all know plenty of people who've had these exact symptoms and they go on to have a mild course and they get over it just fine. But I suspect, which this has been shown in mouse models in research, I suspect that's exactly what's going on, is the virus is infecting that olfactory nerve that way. The other mode of transmission supposedly is through peripheral nerves, and it can actually travel back through the peripheral nerves across synapses and get into the brain space that way, also suggested by this paper. Again, none of this has actually been studied with coronavirus yet that I can find, but it's possible.
Well, there'll be a lot of studies for a long time on the coronavirus as we get through this and in the years to come for sure. But to pivot a little bit, you talked about how elective surgeries aren't being done right now. How is that affecting your work? You know, many people might think that brain surgery is something you can't really put off. If you need it, you need it. So how is this affecting you directly?
Well, so I'm a general neurosurgeon. I do brain surgery, but probably 80% of my practice is actually spine surgery. There are true spine and brain emergencies, and we're still doing those. But there are brain and spine cases that are elective. Brain surgery can be elective. It just depends on the scenario. There's certain tumors that are non-cancerous and slow growing that can be taken out in a fairly elective fashion and just sort of followed, as long as they're not symptomatic. We of course do this as a routine part of our practice, even when a pandemic's not going on. But there are plenty of things that can't wait, and we're taking care of them. We're just now reaching the testing capacity to be able to test patients regardless of the emergent nature of the case, for most instances, I would say. Test them for the coronavirus before they go to surgery. And that is important. There is some anecdotal evidence out of China and France that showed that a certain number of patients who were operated on during the prodromal phase, or sort of the incubation period of the virus, had pretty bad outcomes with elective surgery. So besides conserving PPE, there is significant danger and operating on patients who have the coronavirus. Here at Norman Regional, we just had our first case on a known positive coronavirus patient. My partner did a cerebral abscess resection in the right temporal lobe on a gentleman who's doing really well. Fortunately, his coronavirus situation is very small part of his clinical course. He's relatively asymptomatic from his coronavirus, thank God. So he's doing well, and hopefully my partner and everyone else who participated in that surgery will do well and contract the virus.
I think it's comforting to know that we can actually test before there's any symptoms. I think that, again, not only protects our healthcare professionals, but, you know, again, allows us to care for everybody involved. So that's really exciting to see that we can do that.
Yeah, it's an improvement.
Well, touching on how job has changed, but in many ways, this situation has forced us to do many things differently, which again is no different for healthcare. I know that Norman Regional for quite some time has had virtual visits. That's not something they've just created. And I'm so grateful we had that in place because it made it much easier to transition to trying to do as many virtual visits as possible. So I know that all of your primary care doctors and many of your specialty doctors are now conducting these virtual visits more and more. Can you tell us how those visits work and you know, maybe some steps on how to get one if you might need one?
Yeah, absolutely. The virtual visits, what we're doing right now is our patients who we had scheduled to be seen as a regular clinic patient in our office, we're arranging for them to be seen virtually. It basically involves the patient downloading an app to a device. Obviously, some and plenty of our patients don't have the means to do that. Some of it's just the actual device or the actual hardware to do it. And then some just, you know, aren't technically savvy, kind of like me, and they just don't understand how to do it. And so we do all we can to work people through that process whenever possible. If all else fails, we can have a telephone encounter. That is something that is allowed now. It's changed by the CMS, which is the Center for Medicaid and Medicare Services. They're allowing that as a means of visiting with patients just over the phone. But basically, once that app is downloaded, it allows you to connect and you enter a virtual waiting room. And I have my app on my phone and I can see that I have a patient in my waiting room, and I click the button and they come up, and it's kind of like a FaceTime visit for people who have Android or iPhones. FaceTime is kind of a known thing. I've actually used FaceTime, giving patients my personal cell number, and we just do FaceTime that way, and when the app fails, which it does sometimes, kind of like we had a disruption earlier in this visit, but it's working out surprisingly well. Patients who've had surgery, we need to look at their wound. They can just hold the phone or turn around and face the computer. It's kind of humorous at times, seeing people in their normal environment showing us the bass they caught and the deer they shot last fall, and it's kind of neat. I kind of enjoy being able to see my patients in their natural environment. So it's working out really well. As far as getting a visit, go ahead.
I was just going to say I can totally identify that. When council had our first Zoom meeting from home, it was a mini show and tell where council members were showing things from their offices. But no, I'm so excited that everyone's been able to, well, for the most part, everyone been able to pivot in this way. And I have said many times that obviously those directly impacted by COVID-19 will never forget what this virus has done to their lives. But society as a whole, once the dust settles, I think because we've been forced to make these improvements and really integrate technology into our everyday business, I think we will be better off for it, again, in the long run when the dust settles.
Absolutely. The efficiency of, sorry, go ahead.
No, go ahead.
I was just going to say the efficiency of some of what we're doing now is pretty amazing, and kind of makes me scratch our head why I wasn't doing this sooner, or others, because it's helpful in a lot of ways. But anyway, go ahead. I'm sorry.
Oh, no, not at all. That's one of the things I'm navigating with these kind of live interviews and Zoom and everything. It is different than face to face, but hey, we're all adapting. But I did want to
Right.
ask, if someone doesn't have a primary care doctor or insurance, but they need a doctor now, how do they find someone in our area?
So Norman Regional has set up a community call center. I'll give that number now. We'll give it twice. It's 405-515-5000. That's 405-515-5000. And that's a number that can be called if you're concerned that you may need testing for the coronavirus, as well as if you need primary or specialty care. We can help facilitate triaging that through that number. And that just has been really helpful as a number anyone can call in our community.
Awesome. I am so grateful, for Norman Regional. I've always been very proud that we have our own health system in our community, but I think now more than ever, we've shown how important it is and how lucky we are to have it. And Dr. Cochran, I really appreciate you making time to chat with me today.
Well, my pleasure. It was my honor, and thank you for having me.
Yeah, and one more time, in case you missed it, the community call center number is 405-515-5000. So thank you to all of you watching. Please be sure to share this video so it reaches more people in your circle of friends and loved ones. Be safe and stay home, Norman. Have a great day.